And what we think is that sugar's the gateway drug, if you like. So what do we give children sugar, don't we? I mean, this is a big fault in our society now. Sugar as treats, sugar for everything, basically. It's probably the only psychoactive drug we give our kids from an early age. We don't give them nicotine, caffeine, alcohol, hopefully. So it's the sort of start. And there's a fantastic video clip actually on YouTube of Eric Clapton. And they say to him, when did you start taking drugs? And he says, like when I was 4 or something. And they're like, what? And he said, yes, because sugar. I used to just stuff my face with sugar. That was the way I knew to calm myself.
All right. Good morning, everybody. We have the special privilege and honor to have Jen Unwin join us today. Great to see you again. I know it's been a couple of years since I last ran into you and David back in, I think it was Denver a couple of years back. And
it was.
You guys continue to do great work, and I know we hear a little bit about David's stuff, with his wonderful practice out there. And I don't even remember, somewhere in the UK. I know you're kind of in the kind of a
northwest in the UK. Yeah,
northwest in the UK. Well, anyway, how you been doing?
Yeah, really good. Yeah, lots going on, and got a very exciting week next week. Running a 4-day intensive conference with Bitten Johnson, who some of you may have heard of. She's like the food addiction guru. We're doing a 4-day intensive for 30 people. And then on Friday next week, we've got, we think, the first ever food addiction conference, and it's in Bristol in the UK. And some folks coming over from the States, and Bitten will be talking, a guy called Paul Early, who's the past chair of the American Society of Addiction Medicine, who's a really great guy and has lots to say about food addiction. So it's the start of a very exciting week.
Well, I mean, I think, when I think about food addiction conference, I think about just about any state fair or gatherings, kind of an unwitting conference of addicted people. It's kind of interesting. So let us, before we get too into this, for people that aren't familiar with you, would you just kind of give us a little background on your background and who you are, if you don't mind?
Yeah, absolutely. Yeah. So, hi everyone. I'm a clinical health psychologist by background, which sounds a bit of a mouthful, but basically, I'm a clinical psychologist that specializes in helping people who've got physical health challenges of any kind, really. So that could be chronic conditions, it could be pain, it could be life-limiting terminal conditions. I worked in the National Health Service over here in the UK for about 32 years. And then about 10 years ago, I started working with my husband, who's a GP over here, Dr. David Unwin. We kind of wanted, it sort of happened that actually I discovered low carb first for myself, because I suppose the basis of the story is I'm a lifelong food sugar addict. And despite being a psychologist, and this was kind of to my embarrassment, could never quite manage my own food, was always losing weight and gaining weight. And probably a lot of you here kind of know that story, that journey for yourself. So I discovered kind of low carb keto about 10 to 12 years ago, and really kind of understood it, and it really made a big difference to me. And David had been feeling very downhearted about all the chronic illness in his practice that would just seem to be getting worse. Whatever he did, whatever tablets he gave people didn't get any better. They just kept adding in tablets, and he was kind of a bit depressed about the whole thing. And looking back, was probably pre-diabetic himself. He was kind of gaining weight, very sleepy in the afternoons, not feeling so well. And so I went low carb, did really well. He did it. And then we thought, why aren't we doing this in the practice? We didn't really realize at the time we would be doing something a little bit controversial in the UK. No other doctors had tried it, but we started a group for patients with pre-diabetes and type 2 diabetes. And the results have now written up. The project's still ongoing. The practice is saving £60,000 a year on drugs for diabetes alone, in comparison with neighboring practices, as well as people coming off lots of other things like blood pressure medication, antidepressants, et cetera, et cetera. So the project is ongoing and has been written up in a few papers, and now they've got well over 100 patients into drug-free diabetes remission. Some of them who had really bad blood sugar levels at the beginning, were on insulin and all sorts. We've had people lose. Are we talking stones? I know you guys talking pounds, don't you? But someone's just sent us photos today of a guy. He must have been, Davey couldn't even weigh him on his medical scales. This guy was really, really obese, and now he just looks like a regular Joe. And he was definitely a food addict. So I helped him a little bit with understanding that. So where did I get to? Yeah, so we started that. I retired from the NHS because they didn't really like psychologists who spoke about sugar and food and nutrition. So I thought, right, okay, I'm kind of going to come out and go alone. So that project continues, and now I trained with Bitten Johnson, and I myself specialize in running groups for people with food addiction with a nutritionist colleague of mine called Heidi Yever. And we've been collecting data in the UK and with a couple of US colleagues and a couple of colleagues in Sweden, because there's nothing published at all for people with food addiction and how do you help them. So we designed a group study, and we're going to present the first set of data from that in Bristol, and we think it's just about the first international data on how you help people with food. Lots of people talk about food addiction. They talk about, that we should do keto and low carb, which I do believe, but there's very little sort of published outcome data. So we're very excited about that. Yeah, so there's lots happening. It's a very exciting time, and I do feel, compared to 12 years ago, the tide definitely turning. Lots more doctors in the UK, practice nurses, people actually talking about using this approach with people with type 2 diabetes. And even over here now, the British Dietetic Association, we wrote a paper with them, and they're now recommending low carb as an option. 10 years ago, when David spoke at his first conference, he was shouted down by the dietitians who couldn't believe what he was saying. So I think things are, the tide is turning. I think we have reason to be optimistic. And before I die, I want to see food sugar addiction as a recognized diagnosis in the DSM, which is the Diagnostic Statistical Manual for Mental Health Disorders, and recognized by the World Health Organization, who publish a thing called the ICD, which is the International Classification of Diseases. We've made one bid, which they rejected, mostly based on the fact that it would be too difficult to do. So we're going to go back to them with another shot at that. But that's my next big aim. Yeah, so I suppose that's me in a nutshell.
Well, that's a lot of stuff going on, and congratulations on that. Just somebody sent me, it was kind of funny. There was like the top dietary Google searches of the last 5 years, and we can see how it's changed. It was Weight Watchers, and then keto took the place. And what I was obviously seeing is watching the carnivore diet go up the chain and then pass the vegan diet. And then, it's ramping up. Pretty cool. It's just pretty neat to see. So people are really interested in this stuff. You mentioned sugar addiction. The critics would say the reason you're a sugar addict is because humans require sugar. It is, there's people that say it's vital for our, it's every cell in our body uses glucose, and sugar is what we run on. And that's why you want sugar. It's not because you're an addict. It's because that's normal human physiology. Mm-hmm. What would you say to that sort of?
Yeah. Well, I mean, there's loads of answers to that, aren't there? I mean, one of which is you and I would both be dead.
Right.
There's some hard evidence. I mean, how would humans have survived winters? How did the Eskimos live? It just makes no sense at all. And also the body, the body's really clever, isn't it? It makes you do need a bit of glucose, don't you, for certain functions? I think it's the brain and the eyes are the main bits. But we make that. Aren't we clever? We make that from protein, and is it fat? I don't know all the details, but I know that we can make enough to keep the brain running. And that I love the fact that in our bodies at any one time, there's 1 teaspoon of sugar equivalent, glucose, really. This is 1 teaspoon of glucose in our bodies, our whole bodies at any one time. There's 60, David's got these famous infographics. I don't know if people have seen them, where he just shows you the equivalent teaspoons of sugar in various foods. One banana has 6 teaspoons of sugar. Nobody even needs to eat 1 banana.
Yeah, I mean,
You
I
can,
think you're referring to the blood glucose, how much is in our bloodstream. We have a little
yeah,
bit in our muscle and liver, but yeah, your point is well taken. Yeah, we make
yeah,
plenty,
bloodstream.
and
Yeah,
it's from
thank you.
glycerol from fat, from triglycerides, and then obviously many of the amino acids become gluconeogenic. So yeah, interesting.
Mm, yeah. So
So
yeah, so
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 tell-
yeah, yeah, totally zero need for ingested sugar, I would say. Um, and you're an extremely active person.
Mhm.
I I tend to eat one meal a day, so I just eat in the middle of the day, and then the next morning I go for a run or I go to the gym and lift some weights, and I don't notice anything at all. I'm completely fine.
Yeah, I'm like I think I'm trying to where we're at. We're at about 10 o'clock, 9 o'clock in the morning here. My last meal was about 2 p.m. yesterday, and I'm still here. And, did all my stuff.
Functioning, yeah.
Wrestled with a bunch of people last night. I'm a little sore from that, but so as far as I think we interviewed Joan Iflin, who is another person who talks a
Yeah.
lot about. I'm sure you're familiar with her with food addiction, and so when you sort of, how do you justify that as a diagnosis? Because that's a goal of getting an ICD-9 or ICD-10 now, I guess is what
Mm,
it is, and in the DSM, I think it's 5 now. What criteria are you using, and how do we say it's truly an addiction? Because a lot of people say no, it's not an
yeah.
addiction. It's not. You're not like an alcoholic. But how do we justify that diagnosis code? I suppose.
Yeah, yeah. Obviously, not everybody is like not everybody who gets exposed to alcohol becomes an alcoholic. So that's the first thing to say. We're not saying sugar is addictive for everyone. It has that capability, like alcohol, nicotine, and other drugs. And I have a useful mnemonic that we've developed for the symptoms that you'd look for, and these are actually taken from the ICD symptoms for substance use disorder. So I'll just run through them, and people in the audience can maybe count up themselves, or maybe kind of raise your hand or write something in the chat if you recognize yourself. So I'm going to read out the 6, and you need 3 or more to get a proper. Obviously, it's not a diagnosis because we're not doing a proper interview, but to get a probable sugar addiction problem. So the acronym is CRAVED, and the first symptom is compulsion, or so cravings and compulsions. And this is that experience of craving or compulsion, which is so strong that you find it impossible to resist. So you wake up in the morning, you say, no more biscuits today, no more cake. And then you get to, like, say 11 o'clock, and somebody in the office has made cupcakes with frosting, and they put it under your nose and you watch your disembodied hand reach for that cake and eat it, and you think, oh god, I've done it again. Or you get home in the evening, yes, someone's raising their hand already. You get home in the evening, and you've done really well all day, but the biscuit barrel's there, you see it and you kind of reach for it, or you go through the drive-through all the way home. So compulsions and cravings that, despite your best intentions, you find it hard to resist, is number 1. Number 2 is R, and R is reaching for more. So, and this basically is a kind of tolerance effect. So, what you get with ultra processed foods, the sugary, carby foods, is you get that kind of, you get a hit. It's literally a kind of dopamine, serotonin hit in the brain. But like other addictions, like alcohol, you begin to tolerate that, so you don't get the same nice effect. You have to have more and more to get the same effect. So maybe where 2 biscuits was all right back in the day, I mean, I can never remember that day for me. I must have been about 3. You need more and more to get the same effect. And what the brain does, basically, it doesn't like these high levels, these weird high levels of dopamine that we get from ultra processed foods. So it knocks out a few dopamine receptors, and that's why we need more and more to get the same effect. So it's a bit like insulin resistance in the sense there's lots of dopamine knocking around, but it's not being transferred between the neurons, so you're not feeling the effect. So that's R is tolerance, sort of reaching for more. A is for activities um, sort of ignored or stopped. So another thing that you find with addictions is that people become so focused on the thing that's giving them this dopamine hit, they become purely focused on that, and they stop doing all the other things that might give them that sort of feel good feeling, like sports or going out with friends or achieving other things in life. They become sort of obsessed and focused with the thing. So A is for activities sort of are diminished. V is for volume. And what we see is people eating more and more, having more than they intended, going back for more, needing these big volumes of food. E is for exclusion. This is where you get kind of withdrawal symptoms if you try and stop. So people often say, oh, sugar isn't addictive because there's no withdrawal symptom. They probably haven't tried giving it up. I've certainly had lots of withdrawal symptoms when I tried to give it up. Shaky, headaches, gastrointestinal, miserable as sin for about 9 days till the lights went on. So that's withdrawal symptoms is E, and then the last one is D. And for me, this is the almost like the sort of hallmark of addiction, which is continued use despite damage. D for damage, and this is where you or maybe someone in the family really thinks that your physical or mental health is being harmed by this behavior, but you can't stop. You continue to do it despite your best intentions. So I think that really the point is that we're driven to do this stuff. It's a brain disease. We're driven to do it. It's not our fault. These ultra processed foods have hijacked our brains. Intelligent people continue to do things which make no sense. And so those are the 6 criteria for substance use disorder in the ICD. And I'm sure people who are listening can see that they apply to food. We all, even if those of you listening haven't got that problem, we know people who continue to eat despite having type 2 diabetes, being overweight, it causing them mental health problems like anxiety and depression, etc., etc. I mean, I did it. I did it myself, and I considered myself to be competent in all other areas of my life, but in that area, my brain was just wired in that way. There's possibly some genetic component. My mother was definitely a food addict, and often when I interview people, they have other people in the family, sometimes with alcohol problems. A lot of women have dads who have alcohol problems, and it's kind of transferred into an eating problem for them.
Yeah, it's interesting, I mean, because obviously crave, you have to put everything into a fancy acronym. So you have to kind of make things fit. But I mean, the hallmark is, you're causing damage to your body and you can't stop it, basically.
And you can't stop. Yeah,
right.
that's the nub of it for me, is that people are doing something that's kind of against their better judgment. And when you look at how things are going in society with the health of people in general, kids, you can't think what else, what other explanation is there for people doing that. But as I say, it's not our fault. I truly believe that the food companies know that's they've designed foods to be irresistible. There's lots of, it's been written around about a lot, hasn't it, how the food scientists have kind of literally designed these foods with sugar, salt, fat, these combinations that as humans, because of the way our brains evolved, so that we survived the winter, so we would overeat nuts and fruit, or anything we found that was in that kind of ilk. They've exploited that, really, that sort of human that, and it's cheap stuff, we keep buying it.
Yeah, I mean, I think for the Bliss point, that Moskovitz was a guy, I think, that sort of really coined that term. And it's interesting. I find the interesting aspect of it is the salt aspect of it, because I'm just trying to think, sort of primitive humans, where they would be like craving salt, or why that would be an interesting. But I guess it is. I mean, apparently it is. And, clearly the food companies don't have our health in our best interest for our health. That's clear. It's profits.
I guess it's funny, the salt one, isn't it? Because I think it's when it's in combination with those other things, isn't it? It's a bit like nuts. They're quite easy to overeat, but if you roast them and put salt on them, then they're really easy to overeat. There's something about us wanting that salty flavor, isn't there? I mean, I love salt, and I don't limit that, actually.
Yeah, no, nor do I. And there's, I know that there's people go back and forth on that one, but it's kind of interesting. I think that the difficulty here is some people will still maintain that, well, we don't necessarily believe that a carbohydrate-based diet, or a sugary diet is actually causing damage. They'll say, "Well, it's not that; it's just that you're overeating, and so we can't blame those foods." But inherently, like somebody said, one of the principles with modern dietetics is, well, moderate, balance, and it's like you can't moderate. You can't tell someone to moderate foods that they can't moderate. I mean, it just doesn't work. It's just bad advice.
Exactly. And
Yes.
then it's bad advice because it doesn't work, but it makes them feel more ashamed. They go through this repeated experiences of failure with diets and programs that are about moderation or that still include carbohydrates and sugars. Like the kind of points-based systems. Or whenever I did Slimming World or Weight Watchers, I would just save up all my point. I'd eat like zero stuff all day so I could have a cream egg at night, which is a sort of chocolatey. I don't know if you get those in the States, which is ridiculous looking back, but totally fits in with this sort of food addiction model. Just like you wouldn't tell an alcoholic to moderate. It's exactly the same. You wouldn't tell an alcoholic to moderate their whiskey intake. You just tell them to quit. So
Yeah, and it's interesting because we have this. I mean, clearly, there's people that are having success not moderating, like going, low carb, zero carb, and yet there's such a pushback that how dare you do that? And yet they're getting results and they're getting healthier and they're happy and they feel better. And yet they're being told, you can't do that. It's bad for you. Why do we have that? Why would anybody care how you get successful? I mean, what is the pushback on that coming from?
I mean, I think there's obviously the history of all the history of the medical training going back. They were taught one thing, so they find it hard to sort of accept something else. I think the other thing is that it's really threatening to anyone who has a bit of an issue themselves that you've given up. I found that a lot. When you say you don't, I don't eat, I don't eat sugar and carbohydrates. The people who feel really challenged by that are the ones who probably don't think they could live without them. so you do get that pushback. I think it's just we've just got to get that paradigm shift going, particularly in the medical profession, that it's okay and that people do get good results, sustainable results, like David's data now over 10 years. Absolutely everything improves. He's looked at everything: kidney function, lipid profiles, blood pressure. I mean, all the things that you could possibly and historically people have said, oh, it's bad for your kidneys, it's bad for your lipid profile, and none of that has proven to be the case over sort of 8 to 10 years. So I think that's the main thing. We need to keep pushing back with the data and the results. And what I've loved about this whole thing is that actually it's like a virus spreading from the ground up, that people have good results. Like here in Southport, David's patients would have good results, then their family take it on board, they chat to their neighbors, they take it on board. And we often hear stories about, like, even just down the road where we live on two farmers, one Wi-Fi engineer, a tomato grower. They've all just spoken to us over the years and quietly had a go and lost weight, improved things like chronic pain from arthritis and autoimmune conditions. And so it spreads like this virtual virus throughout society. And I think that's a really powerful thing.
You had alluded to that, there may be a sort of a familial inherited pattern in here. Is there any, do we have any, like, other than, yes, you're obviously addicted, can we look at someone's brain? Is there like a functional MRI, or is there some sort of genetic profile or anything any commonalities for people? Because you said some
Between
people can,
people, yeah, there's something about I haven't looked into it in a great deal of detail, but there's something about the genes and the dopamine signaling, where it looks like people with food addiction get this kind of exaggerated response to certain foods. And as we were saying before, in terms of evolution, that was probably of a benefit, because we'd be really driven to go looking for stuff. we'd be foragers and getting food and surviving through the winter. And also that ability to sort of put on weight really easily would have been a good thing, right? That's why we're here today, because our ancestors did that. Yeah, so there does seem to be something about the dopamine signaling which is a little bit unique to the food addict brain. But as I say, it's not something I've particularly looked at. But there's lots of imaging studies that have been done, and it looks very similar in the brain to all the other addictions, alcohol, and drugs. It's all in that same sort of primitive part of the brain.
One of the things that I've been sort of somewhat surprised, I see it all the time now, is, when we get people to maybe correct this underlying food addiction, they clean up their diet, addictions, like smoking and alcohol
Yeah.
seem to also get better. Why do you think? Is that just because the same pathways are being stimulated, or what do you think's going on there? Or do you notice that as well?
Yeah, definitely. So it's definitely this thing called addictive interactive disorder, and it's sort of a well-known thing that, yeah, because it's the same part of the brain, everything's a little bit connected. And what we think is that sugar's the gateway drug, if you like. So what do we give children sugar, don't we? I mean, this is a big fault in our society now. Sugar as treats, sugar for everything, basically. It's probably the only psychoactive drug we give our kids from an early age. We don't give them nicotine, caffeine, alcohol, hopefully. So it's the sort of start. And there's a fantastic video clip actually on YouTube of what's that famous guitarist? I'm having a senior moment, Eric Clapton, and they say to him, when did you start taking drugs? And he says, like when I was 4 or something. And they're like, what? And he said, yes, because sugar. I used to just stuff my face with sugar. That was the way I knew to calm myself. And then that often leads into other things as people get older, alcohol or smoking, to try and get that hit. And the other effect that you see is that when people give up alcohol and smoking, they often put on weight or start eating more sugar. It's another way to get the dopamine hit. And also that we know that when people have bariatric surgery, for example, and they're prevented from overeating, they oftentimes do start drinking. That's actually an effect where they start drinking more alcohol and trying to get it in other ways. So it's there's some idea now, isn't there, that actually going ketogenic diet would be a good adjunct treatment for people trying to come off alcohol and drugs. So I think the field is moving forwards, that this is starting to be acknowledged, that we need to sort of tone down all the things that we're doing to get these dopamine spikes that aren't good for us, and that helps us then to sort of heal the brain, literally, really, to get it into a more balanced state.
Jen, you've been doing this for a while now. What have you seen, like, from, like I said, if obviously 20 years ago or whenever you started this, you would have a different approach than you do now. What things have you discovered don't work? And then what are you discovering that actually does seem to work?
So what works with helping people to recover from food addiction? So number one is the foundation is abstinence. Trying to move forward to an abstinent food plan. So that can be, I mean, obviously carnivore, fantastic. I mean, in a way that's ultimate, and people can, but sometimes that's a bit scary for people to start there, but they could start there potentially and then try experimenting, adding things in if they want to, and see what triggers them and what doesn't. I know a lot of food addicts have tried carnivore, and then some stick there, and then some kind of add a few things back in. So definitely that. So low carb, keto, carnivore, anything that cuts out sugars, grains, and ultra processed foods, and then any of the foods that you personally can't moderate. So I personally can't moderate cheese. I think, and nuts, because they have that sort of kind of fat carb thing going on. Cheese particularly, quite, and other things going on with dairy. So I've had to cut those out over the years, but that's a personal thing. So anything you can't moderate, or you eat despite not wanting to, or trying not to, if you like. So to start there, but then and for many people, they can then stick to that. But a true dyed in the wood food addict, maybe with some added in sort of eating disorder features that might have come from all this, you know, weight loss, becoming kind of a bit obsessed with body image and all of that, they need really quite a lot of support to keep the maintenance going. So definitely to joining a community like this, to, you know, to have that support to keep going with the behavior, and then to try and add in other things which give you the dopamine, the serotonin, the endorphins, all of those things, not from the food. So exercise is brilliant. I can see someone exercising. I'm very much approving of that. You're going to get dopamine, endorphins, you know, serotonin. If you do it with other people, probably a bit of oxytocin. So that's all good. So exercise. I mean, anything really that's more of a sort of like a real pleasure in a sense, like gardening, whatever it is for you, whatever gives you joy, gardening, music. I'm trying to think, yoga's a really good one that kind of hits a lot of those things as well. So trying to get people into these good sort of recovery habits, where they're getting what they need, not from the food. And, you know, maybe where there are issues of trauma, sometimes you know, people are food addiction, but, you know, maybe with trauma which added into the sort of emotional eating, the eating to sort of numb out. You know, sometimes people need to look at that a bit, or, you know, get some professional support with that. But it is mostly the transferring to the clean nutrition with support, however you manage to do it, bringing in these other things that are going to support your recovery, and then staying in some kind of community, because it is a lifelong problem once you've got it. Like alcohol, like an alcoholic can't go back to just having one drink after a couple of years of sobriety, because in the background, you know, it's still going on, and you go right back to where you were. You don't just kind of start from ground zero again, like, you know, like as we all know with people with an alcohol problem, they would go straight back into it. And it's the same with us. And again, there's a sort of explanation for that in the brain, in that I said about the dopamine receptors being downgraded because there's so much dopamine slopping around. Once you stop eating those foods, the dopamine receptors reform or regrow, because they're trying to now mop up every little bit of dopamine they can get, because there's not so much around. So then when you go ahead and have that cupcake after a year, there's more dopamine receptors, and you get this massive, the lights going off, and then it can be really hard to get back on the wagon again, because you get this kind of massive reaction. So it's important to sort of remain in the abstinence with recovery. But there's quite a few groups and things going on now. I've got a clubhouse on a Wednesday night, if anyone's interested, 6 p.m. UK time. It's called Fork in the Road. So people can come along and join with that. There's a couple of other groups in the States that are free for people to join in if they feel they need that extra bit of support to stay on the food recovery road.
What is the sort of the prevalence of food addiction? Listing in specific populations, could we say everybody that's obese is a food addict, or 90%, or diabetics, or what does it look like?
There's been various studies done. So general population, it tends to come out about 8 to 10%, which is quite low, I think. So we've worked out that equates to 4.3 million adults in the UK, but obviously it's going to be factors more in the US. There's a massive overlap with bulimia and binge eating disorder. So maybe 90% of those people have a food addiction problem. And question mark, is binge eating disorder actually food addiction? I'm not sure that eating disorders guys would agree with that, but there's such a big overlap. There does seem to be some evidence for that. And then anything in between. So obviously there are quite high proportions of people with obesity, but not everybody. Some are more in that what we kind of call maybe harmful users. So they might look a bit like food addicts, but actually they can stop slightly more easily. It's just bad habits that they've got into, overeating on certain occasions or weekends, that kind of thing. And in people with diabetes, there have been studies done, but the prevalence seems to vary wildly between the studies, between sort of 20% and 80%. So, but it's definitely a factor in type 2 and type 1 diabetes, actually, partly because people with type 1 are kind of given sugar as a sort of safety mechanism, so they that has that added psychological sort of effects for them as well, that they feel it's sort of keeping them safe. So yeah, varied prevalences depending on which population you're looking at.
And what about, is there a sexual dichotomy, male, female, or an age sort of range that we see this in?
So lots more females than males come forward for help with food addiction. And lots more males than females come forward with alcohol problems, but that may be a sort of almost like a cultural bias. I suspect there's a lot more men with food addiction problems that don't come forward or don't see it as an issue as women. But it's certainly in our groups we get, maybe 80-20 women, maybe more. In terms of age groups, again, the people presenting tend to be middle-aged people, middle-aged women who are sort of saying, I've tried everything. You're the last house on the street. I really need help. But I suspect we've got a ticking time bomb in terms of the young people, just because of the environment they've grown up in. And I think we're going to have a problem with our young people going forwards.
Yeah, and I think when you're seeing the older folks, middle age and on, because this is when the damage starts accumulating, and you start to see
Yes,
the diabetes and the depression and the obesity and the joint pain and that stuff. And
correct.
some people I think most people don't like that situation, but some people are willing to change their diet. What are the traditional success rates? And are you guys able to move the needle on that with what you're doing?
Yeah, I mean, I think there's not very much evidence, as I said, hardly any actually, about what are the success rates. I suspect they're similar to other forms of addiction, which is probably about a third. So in the data we're going to present at the weekend, we have got significant improvements in the craved assessment and the Yale food addiction scale, which is used in a lot of the research. And in terms of well-being, so mental well-being, people are getting a lot of benefit from attending the groups. So the treatment is helping. We're going to follow them up for 2 years, because one thing I can never stand is studies that say, our treatment worked, and they literally haven't even followed. It's only before and after, they haven't even followed them up. So we're going to be doing 6 month, 18 months, and 2-year follow-ups, because you need that time scale with people with addiction, because they're going to struggle up and down in between. And certainly we've seen that even in people who did really well while the group was on. Now we've gone into the sort of follow-up phase where we're just doing a once a month support Zoom. We have had people really, really struggling, but they're managing to sort of get back, and we hope that after a few iterations of that, they'll be doing better by the end. But yeah, who knows? Actually, it's a great question.
How much overlap do you see? Because you mentioned that, a lot of people, um, well, we talk about alcohol, but do you see a lot of overlap between a food addict and someone who's also an alcoholic or a smoking? I call it a smoking addict, quite honestly. But
Yeah.
is there a lot of commonality there where people have multiple, I guess, comorbid
Yes.
addictions?
Yes, definitely. Yeah, particularly alcohol and food. That's a really common one. And I mean, Bitten talks about it. That was her. She got treated for alcohol problems, and then it was only a few years later, when she was clean from the alcohol, she realized that she actually had exactly the same problem with foods and with sugar, and she calls it sugar addiction. She says it's not food addiction, it's definitely sugar addiction. That's how it starts. um so yes, there is that comorbidity because of that common brain pathway.
So, because you mentioned, people get a gastric bypass and they can no longer, get that hit from eating some, excess junk food. And then
Yep.
they go into alcoholism and they have higher suicide rates. The data on bariatric surgery is not particularly pleasant when you look out long term with all the problems they have. But so it's probably
Yeah.
not the best way to lose weight. But do you know, so instead of substituting I stopped smoking, now I'm eating sugar. How do we fix that? Is there positive substitutions that we can do that can provide us similar things? Me thinks exercise, but what are your thoughts on that?
Come and say hello. David's just popped
Oh,
upstairs.
good. Hey, there he is. Hey, man.
Hello.
He's
Yeah.
checking on me.
I was
So-
hoping I get to do a podcast with David at some point. So
Yeah,
You
definitely.
may.
You've got him, yeah.
we'll reach out and get things scheduled. Awesome. Well, keep up the good work, by the way. I love what you guys are doing.
Thank you.
Definitely exercise, as I was saying before. I think that's a really positive substitution. The only slight caveat is that those of us with addictive brains are very all or nothing. So, there's a temptation for us to get absolutely obsessed with exercise. And that happens, doesn't it, with people with eating disorders, where they're trying to, I think people definitely have to see it as a mental health tool, not a weight loss tool. I think that's really important. Be at your best, enjoy it, get those endorphins, feel strong and good and healthy. Don't be slugging away on the treadmill for hours to burn off the whatever it was you had. That's just eating disorders talk. But yeah, definitely enjoy it. We were designed to move, weren't we? Again, going back to I love to go back to the evolutionary piece. We were designed to work and move and be with other people. And I think if we go back to thinking about how we evolved, it can give us a lot of the answers. Yeah, move about more, be outside, get outside as much as you can. Sunshine, fantastic. For so somebody outside walking, how fantastic. Get your serotonin, your melatonin reset. All of these things are connected. Think of yourself as you would have been, on the African plains, and less as we are, kind of stuck on Zoom in the dark. Do as much as we can to be more primal, I guess. It would be my advice. I think it just resets the brain in so many ways, and that's the same with the food. So be primal with your food, be primal with your activities, spend time with family, get off the screens if you can. It's not easy, is it?
This will be a controversial topic for many people, but what about coffee? Because a lot of people have like kind of a coffee addiction. Is there some role for coffee in this? How does that play in?
Well, people have, I think with coffee, it's kind of, you've just, again, got to be honest about how you are with it. If you're fine with it, that's fine. I was always kind of on the drift to more and more. Number one. Number two, I'm a migraineur. So and I get used to get quite a few headaches. And I did wonder if caffeine was part of that, because I had this ridiculous experience where when I went for my CAC scan, so this is the calcium artery scan, because I had incredibly high cholesterol. So I thought, right, I'm going for this CAC scan because the GP kept wanting me to have the old statins. Right, you're not allowed a caffeine on the day of the test, and I think the test was like at 1 o'clock, and I normally had about 3 really strong coffees by then. I was incapable of driving to the test. Fortunately, David was having the same test, and he's not quite as reactive to caffeine as me, so he was fine to drive. I had my head felt like it was exploding, so I went first, had the CAC scan first, got a 0 score, which I was really pleased about.
Yeah.
And I'd taken this little flask of coffee with me, so I sat in the waiting room while David has his necked this coffee and felt instantly fantastic. So I thought, this is wrong, this is really bad. So I started to wean it down really carefully. Went half and half, and so I still drink decaf, but I personally don't drink caffeine anymore. But I think that's a really personal thing. Bitten Johnson's a big coffee fan. I know Doc Sybes, he's all about carb addiction. He drinks coffee, doesn't he? So I think it's a personal thing, really. I gave up alcohol because that is triggering for people with food addiction, because of the same part of the brain. I never drank much, but when I did, it just made me more hungry, more cravey. I wanted to I was much more likely to go off track. So I've given up everything, really.
Yeah, if you want to make bad decisions, drink a lot of alcohol regularly. That doesn't bode well for any kind of decision. Let me ask you, do you know of, or are you aware of, like, one of the things I had some friends that were in, rehab and addiction programs, and they would just say they would serve them junk food. I mean, it was just
Yeah.
You know, and are there any places that are like treating like drug addiction with like a healthy diet while they're there? Do you know of anything that does that?
I know, I believe there are, and I think there's somebody on the. I don't know if people have heard the Food Junkies podcast. It's absolutely superb. So if this is an issue for you, or you know somebody who might benefit, there's a podcast called the Food Junkies podcast, and it's Vera Tarman, who's another author in this space, and she wrote the Food Junkies book, and she runs recovery programs herself. Either this week or last week, I think they've had somebody on who runs an integrated program where they take people with drug and alcohol problems, but who may have comorbid food problems. So I'm pretty sure they probably into feeding people. And I know there are some trials ongoing to help people with drug and alcohol problems with ketogenic diets. I saw a tweet by, I think it was Chris Palmer, isn't it, who's one of the psychiatrists in this space. Yeah, these ideas are coming, I think, where we need to get the two worlds aligned, really, the sort of, you know, the psychiatry, the addiction world, and the keto carnivore space. I think we can all link up with a lot of good stuff to do.
Yeah, I know that, like I said, you know, we've seen a huge sort of push towards diabetes, which I think is great. I mean, it's such a huge problem, but I always feel like we're leaving a lot on the table, and we're seeing this with the depression and addiction, and really just about every single chronic disease out there is dramatically impacted by diet.
Mm,
And so that's
yeah.
the really neat thing. How good are you? Let me ask you: are you part of David's practice? Are you completely separate? Do you have your own thing, or do you guys work together? And he funnels you.
I kind of help him. I sort of work. Yeah, I help him on a sort of voluntary basis. So tonight, for example, we've got a Zoom meeting a bit like this for all the low carb patients, and we're actually going to be talking about addiction as well. And I sometimes do sugar addiction assessments on his patients if he feels that would be helpful. And basically, I coach him to, you know, on how to help people and how to sort of have those conversations. So I'm separate, really, officially, but I kind of volunteer help. And then I'm tending to focus on running these groups, organizing this conference. I've written a book called Fork in the Road, which is all profits to the Public Health Collaboration who are campaigning on these issues in the UK. And we're just bringing out now a journal as well, so people can keep kind of daily accountability and for themselves. So and again, profits to the PHC. Yeah. So I just please myself now, really, what I want to do, what I'm interested in.
Oh, that's great. That's wonderful. Do you so like when because I take care of a lot, I do consultations still with people, and a lot of them struggle with a relationship with food, whether it's food addiction or not. I suspect that's a case for a lot of both men and women. I tend to see more men because for some reason men relate to me better than women for some odd reason.
Yes.
But
Yeah.
it's kind of
And I think the whole meat thing sits really well, doesn't it?
right. But it's kind of interesting because I talk about, like I said, weight loss is not the primary first goal. I think it's addressing the food addiction problem first, and whether what you got to do, and how do you, I mean, because a lot of people just come because they were so interested. Most people are overweight. Most people want to lose a few pounds. Maybe it's a stone or two. And for you guys who don't know, stone is 14 pounds. I used to be 20
Yep.
stones. I know.
Yeah.
But, it's something that, uh, so how do you, like, you get a new patient, or a new client that is food addicted? What is the initial intervention look like for you?
Yeah. I think it would be about helping them to work out what should be what their abstinent food plan would look like. And obviously for you, that's going to be more like your guys, that's going to be more like a carnivore plan. Initially, it's not weight loss initially. We were discussing this last night on Clubhouse, actually. Really, people just need to correct that physiology, that brain chemistry. But then if for people with food addiction, there may come a point where they're struggling with amounts, even when it's meat and fat. I know, we all say it's quite difficult to overeat meat and fat, but those of us with, dyed in the wool food addiction can also, you probably come across people who can overeat.
Absolutely. Yeah, absolutely.
And then, that there is then, maybe that possibility of a conversation around around weighing and measuring. So most of us really resist that because we don't want to go back to the diet thinking, but it can give us those stabilizers, I think, this is the amount I'm going to eat today. And I could eat it in 2 meals or 1 meal or even 3 meals, but, that's the amount. And I need to stick to it really and to sort of get in the habit. And it may even be short term of actually weighing and measuring the food to prevent that sort of, it's okay to sort of eat ad libitum forever, because some of us can overeat even keto and low and carnivore, and that's definitely I could. Yeah.
Yeah, I can put down a lot of steak. I can tell you, I can gain weight there if I want to. So, but it's interesting.
Yeah. Yeah.
Well, let me sort of ask you for people that want to. I guess primarily, do you work online or is it mostly? I guess you said a Zoom call. So you take care of people just in the UK or is it all over the planet?
Yeah. So I'm not tending to do one-to-ones at the minute, but I can definitely, because I'm so busy doing these sort of groups for the study, but I can definitely recommend, if people want to go and consult about this. For example, there's SugarX Global in the States. I don't know if you've come across them, but they're all really sound. They're carnivore friendly. There's Anna Fruling, Dave Avram Wolf, and his mom Judy Wolf. They're running that, and they have community meetings. There's Molly Painschlab and Clarissa Kennedy who do the Food Junkies podcast. They've got they're called Sweet Sobriety, and again carnivore friendly, very, very knowledgeable about this eating disorder, food addiction kind of complex. So if people are in the States, they can definitely consult with them and either join groups or I think get one-to-ones or get kind of weighed food plan. But I mean, you guys can do that. You can do kind of if people want to weigh and measure, I'm sure you could advise them about that. And then, as I say, I'm on Clubhouse every Wednesday night, 6 p.m. UK, Fork in the Road. I've got the book, and my website is Fork in the Road, and I'm on Twitter at Jen _Unwin, so people can connect with me there or look what I'm getting up to.
Well, that's wonderful. And as far as David's practice, is he getting? I guess I'll talk to him when I talk to him. But I mean,
Yeah.
better is, you said he was a heretic a few years ago. Is it?
Yeah.
Are more people sort of figuring out that this is actually effective and helpful? Is he getting less
For
push?
sure. I don't think he's been shouted at for a few years now, so he's very happy about that. He's got another paper coming out very soon, summarizing all the data from Norwood with Roy Taylor, who's the guy who did the direct studies, this kind of shakes, shakes to cure type 2 diabetes.
800 calorie shakes or whatever it was.
Yeah, 800 calorie shakes. Yeah, and of course that goes really badly for food addicts because the minute they come off the shakes, they just go straight back to square one. So I think it's fair to say that, it is fair to say, because we've looked at the data, that David's data is much better than their data because people have got on the right plan to start with, and with support they're sustaining that. So the things are getting better over the years, but they're getting more relapses as the time goes by. The long-term data isn't as good, and that, I mean, I could have predicted that really, because you need to teach people a sustainable plan, which 800 calorie shakes is nobody can live on that. They have to do something different in the end. What are they going to do?
Yeah, exactly. I got two other thoughts I had that I wanted to run by because we have a couple minutes. So plant-based diets, vegan diets, they're being pushed down everyone's throat. We're seeing that. How does that play? Because we see a lot of people that, particularly people with eating disorders, particularly women with sort of anorexia or binge eating disorders, bulimia, they just kind of transition into a vegan diet. Is a vegan diet a particularly effective diet for treating food addiction or no?
No, and actually quite a few food addiction professionals won't treat people who are eating vegan or even vegetarian diet, because you need the animal fats and the proteins to heal the brain, to make those amino acids. That's just the way it is. And Bitten would say she's never had success with someone, and that's why she doesn't help them now. She says you'll have to agree to transition, onto an animal protein and fat diet if I'm going to be able to help you. So yeah, it's interesting.
And then the other thought I had was the NHS. Obviously, they are a public, not a not for profit private company like we have in much of the U.S. Do you feel that there's more incentive for them to embrace this? Because obviously it's a cost savings. David is saving 60,000
Yeah.
pounds a year. You could magnify that, and it could come into the billions of pounds a year. Is there? Do you think there's an appetite for that within the system?
It's been surprising to us really that it hasn't people haven't kind of jumped on it and rolled it out. I think again it is slowly coming. I think doctors are coming around to it. Certain practices are coming around to it, but not yet at a systemic level, unfortunately. But hopefully that's the next push. And you'd think, wouldn't you, that there would be definitely an appetite for making those kinds of savings.
Yeah, I mean,
Yeah,
I know many physicians. I mean, unfortunately, the incentives, particularly in the U.S. system, it's you're not incentivized to do this stuff. It takes too long. You'd rather just get your
yeah,
15 minutes and shoot them out with a prescription. So it's a very difficult thing. One thing I want to say, because and I'm glad David's doing another paper, because I cite the one where he saw the reduction in chronic kidney disease and people going
yeah,
on a animal protein low carb diet, which again is just more evidence that it's not harming your kidneys, which just seems to still be the prevailing thought, even among the healthcare professionals that are kind of clueless.
yeah,
Anyway, I unfortunately have to run. I've got to go talk to a couple clients and try to get them not to be food addicts or whatever. So
yeah,
anyway, thank you
yeah.
so much. It was
You're
absolutely
so
pleasure talking
welcome.
with you.
I've enjoyed
And
it. Thanks,
I'm looking at
everybody.
you. Are you guys coming over to the States anytime soon, or you got any
We're
travel
coming to
plans?
Minnesota in August.
Oh,
Would you
okay.
believe?
What's going on
Uh,
in Minnesota?
there's a company called Level Two that are providing services to people with type 2 diabetes
Yeah.
to get remission. So we're doing some consulting with them. Hopefully next, maybe later this year or next year, there'll be some more conferences that we'll get over to. So
It's starting to open back up again, thankfully.
yeah,
So
it is for sure.
wonderful, Jen. Thank you so much. And tell David we'll reach out to him. And
Yeah.
it's always a pleasure. Good. Keep up the good work. Let us know once your new study gets out. We'd love to hear about it.
Yes,
Okay? All right.
will do. Will do.
All right, everybody.
Okay.
Take care,
Bye,
folks. We'll
everybody.
see you
Thanks so
guys
much.
tomorrow. Thanks, everybody. Bye-bye.